I really been working on for, I guess it's days. I feel like I haven't drawn the outline, but I think I've been, okay, so there's not a lot. So I can make an outline. Yeah. Yeah.
Rachel, when is your date?
When? September 16th.
The 18th?
16th.
16th.
You know, like my date for this talk.
Yeah.
Sure.
You only have one date that really matters, right?
And then like 2 weeks later, I was yeah. Is that because you have
So I'm going to go ahead and get started because I have kind of using Dr. Norton's approach of a lot of seizure-inducing slides by going through them really fast. But I just gave this lecture a few months ago in this lecture series. If you heard it, or if you just don't care about staying for this one, it's okay to get up and leave because it really hasn't changed that much. So I got asked to do it on fairly short notice because I had a slide set made up. So this is, I'm going to go ahead and get started. So what I'm going to go over, or at least pulmonary embolism, primarily as it's going to relate to those of us taking care of critically ill patients. Briefly, some background information, epidemiology, clinical presentation, in terms of the limitations, what we can and can't use, what some of the tests, what information we actually get from them, some of the diagnostic modalities, Treatment, particularly going to emphasize the submassive group because I think that that's maybe where there's probably the biggest question area in terms of whether you do or you don't give thrombolytics. And I'm going to tell you up front, there's not going to be a direct answer. It's pretty much going to be what you and or your attending decides, and hindsight's probably going to tell you what was the right thing to do in terms of that, because you can probably make a justification either way in terms of your decision. And then talk about risk stratification and treatment strategies. So just for the epidemiology, the precise number is unknown, but the incidence has been estimated to be about 0.5 to 1 per 1,000 patients, and accounts for 60 to 100,000 deaths per year in the U.S. 15% of all inpatient hospital deaths are suspected to be related to pulmonary embolism, and mortality may be as high as 30% when it's untreated, versus 2 to 8% when it's treated. So there's always this emphasis on being able to find it and then being able to treat it when we do find it. Approximately 10% of patients in whom the diagnosis is established will die within the first 60 minutes of that, so it's going to be a catastrophic event. And of those who do die from a PE, about 2/3 of those do so within the first 2 hours. So particularly in the emergency room or when somebody newly presents, that's sort of your window of opportunity to try to affect a change. Probably based on our ability to detect it due to CTPA over the past 20 years now, the incidence of PE, at least detected PE, has been going up. The incidence has been rising, and that's because the methodology to detect it is better. However, the case fatality rate has generally been going down, and that's probably a consequence of earlier detection, earlier intervention, but also the scanners are such that we're probably detecting some embolic events or emboli that may not be that clinically consequential. So these little small subsegmental emboli that we detect may actually, in some patients, may not even need treatment. Mortality does increase with age and male sex. Patients with emboli are increased risk of death within 6 months of diagnosis. So for that patient, at least that's if you've made the diagnosis of PE, and they do have an increased mortality rate, at least near-term mortality rate. 10% of idiopathic or primary emboli will have occult cancer at the time of diagnosis. However, it's not been shown to be economically advantageous to screen patients for cancer. It just doesn't. The yield on the workup is generally low and somewhat costly. 10 to 20% of patients with PE will have a genetic thrombophilic disorder, but again, routine evaluation is not necessary in all patients. In terms of the pathogenesis, I think everyone knows this, it's almost always going to be a complication of a DVT, with the majority of those DVTs being in the lower extremity. However, the incidence of upper extremity DVT is rising. We actually had one at the VA last week, a gentleman with a subclavian and axillary DVT. So you might see some in patients with upper extremities as well. And what predisposes generally is stasis, vessel injury, hypercoagulability. In some cases, like nephrotic syndrome, there may be some instances where you can have thrombosis form in situ. So you may not necessarily have to have, they may not arise, but again, the vast majority are going to arise from a distal site, so it's really a consequence, it's really a complication of DVT. In terms of pathophysiology, the derangements that are primarily going to occur in gas exchange and hemodynamics. Gas exchange, at least in the immediate area, the vessels that are affected by the emboli, embolus or emboli, is going to be a region of increased alveolar dead space. You're going to have ventilation, but you're not going to, at least in that local area, not have perfusion. As a result of that, you're going to lose functional capillary surface area, so there may be some diffusion limitation. And then you're going to get VQ mismatch, and a lot of that's going to be the release of mediators such as serotonin, thrombin, endothelin, things that are going to cause both airway and vascular, both broncho and vasoconstriction. So you're going to get VQ mismatch as a result of that. Cardiovascular-wise, you may get acute pulmonary vasoconstriction and pulmonary hypertension, which generally the right heart doesn't handle very well. So you're going to get an increase in RV afterload. That may lead to some RV dilatation and RV dysfunction and ultimately RV failure. So when patients present, you're going to see this spectrum of patients. You're going to have those with stable hemodynamics and stable cardiac function. At the other end, you're going to have those that present with hemodynamic instability. And then in between, you're going to have these patients that are hemodynamically stable but may show some evidence of right heart dysfunction, or at least biochemical evidence of right ventricular strain or dysfunction. So you're going to have them in between. Again, this group is fairly straightforward in its management. This group is fairly straightforward in its management, but this is the area where, in terms of the treatment decisions, may be a little more complicated, or at least not as straightforward. In terms of factors that predict fatal outcome, comorbidities, if they have underlying cancer, congestive heart failure, chronic lung disease, which we see commonly, they may increase their risk for fatality, mortality. Recurrent PEs have a higher mortality risk. Patients that have pulmonary hypertension that develop PEs may not handle it very well. If you find a right RV thrombus is associated with a much higher 14-day mortality and 3-month mortality, it goes up quite a bit. Elevated troponin levels are associated with an increased risk in both short-term mortality and PE-specific mortality, as is true for an elevated BNP as well. And then RV dysfunction, when it's present, is associated with is a group that's going to have a higher, potentially higher risk of fatal outcome. In terms of the clinical presentation, there's not a lot that's specific. The symptoms, signs and symptoms that they present with is going to overlap with many of the things that we see. Dyspnea is one of the most common symptoms, but it's certainly not specific or unique to pulmonary embolus. And in terms of physical signs, tachypnea is going to be one of the more common things, but again, it's not going to be unique to a pulmonary embolus. So it's going to be, you're going to be taking these things in the context. It may be that there's not another obvious explanation to explain these signs or symptoms, and that's going to lead you more commonly, that may lead you more down the pathway of thinking about a PE. It gets a little bit easier maybe if they have a Hohmann sign, lower extremity swelling or something like that, to raise the specter of a DVT, but still over here. But that may be. In terms of diagnostic testing, a chest x-ray, again, is not going to be very specific or sensitive. Most commonly, atelectasis is the most common abnormal finding, but many patients are going to have a normal chest x-ray. A Hampton's hump, which is this little wedge-shaped peripheral, it represents an infarction. You may see that. A prominent PA that wasn't noted previously, or Westermarck sign, which is going to be a focal oligemia that you may see, may be indicative or suggest the possibility of a PE. EKG, again, not very specific. Commonly, you'll see tachycardia and non-specific STT changes. You may see evidence of acute cor pulmonale or right strain patterns, tall peak T waves and lead tube, T wave inversions, S waves in 1 and L, low voltage in the arm leads, right axis deviation or right bundle branch. And S1, Q3, and T3 is probably the board question that will come up, but it only occurs in about 20% of PE patients. So here's the S, Q, 3, and inverted T waves. So again, if you're looking for it in the right context, it may be helpful if somebody hands you the EKG. This pattern may suggest it, but inverted T waves probably aren't going to be very specific in terms of making you think of that, just bringing it up as a possibility. With regards to labs, CBC, electrolytes are non-specific. They're really going to help in ruling out other things. ABGs, a classic finding is hypoxemia, hypocapnia, and respiratory alkalosis. So they're tachypnic, they're breathing fast, they're blowing off their CO2, yet they're hypoxemic. But hypoxemia may be fairly minimal or even absent in about almost 20% of patients. So the fact that they aren't hypoxemic doesn't necessarily exclude it, but it is one of the things that often brings it to mind, the diagnosis to mind. Patient is hypoxic, but has a fairly unremarkable looking chest x-ray, and often that's what leads us down this pathway. But in patients that have other diseases, COPD, other fibrosis, pulmonary fibrosis, and other things, other patterns can exist or be present in their ABGs as well. The D-dimer is sensitive, but it's nonspecific. It does have, because of its sensitivity, has pretty good negative predictive value. So if it's normal, you can use it to exclude the possibility of a PE when it's coupled to a pre-test probability. So if you have a low or intermediate probability, it pretty well. But if you have a high probability, there's really probably not much point in getting it because it's not nearly 25 to 30% of patients will could still have a PE, so it's not going to be of much utility in that setting, and you might as well proceed directly to your imaging study. So just omit it if you have high clinical suspicion. It's a little more difficult in patients that are already inpatients because often they have other things that are going on that may lead to that being high as well. With regards to other biomarker testing, BNP, an elevated BNP is associated with an adverse outcome. So short-term mortality is increased sixfold if they have an elevated BNP, but it's still insensitive and non-specific for the diagnosis. So it may help with the prognostication, and it may help in risk stratification. So when you get the submassive PE and they've got biochemical evidence of this, it may or may not, but it may weigh into your decision to whether you're going to treat with lytics or not. It's probably where it's going to have the greatest utility. So again, by being elevated, patients are more likely to have an adverse outcome. And the same is true for troponin. Elevated troponin levels are associated with short-term mortality and death due to PE. So you have the odds ratio goes up quite a bit. However, it's not sensitive or specific for the diagnosis of PE, so in that sense. Of those patients that have a moderate to large PE, though, about 30 to 50% are going to have an elevated troponin. And as with BNP, its utility is probably going to be greatest in risk stratification. Normal levels, if it's normal, it identifies patients that may be at low risk or at low risk for developing adverse events, whereas if it's elevated, then it may portend or at least put them in a worse prognosis. With regards to imaging, there are a host of modalities available, although some are really not used very much, but the ones we'll go through are angiography, VQ scan, CT angiography, MR angiography, Dopplers and echoes. Pulmonary angiography is the gold standard. It allows you to visualize both the proximal and distal segments, and in patients where you're thinking about thrombectomy as being a potential treatment, they're probably going to need to have angiography. However, I don't think there's probably too many people in this room that have actually ordered or had a patient that had a pulmonary angiography otherwise. It does carry some risk. There's about a 0.5% instance of death with the procedure. And you get the complications that go with. So basically for the IR guy, it's like putting in a central line. So you have the line complications that go along with it. And then you have contrast reactions. You already have a heart that's in some distress. And then if you induce arrhythmia as the catheter passes through, it's much like doing a swan, that may be a potentially catastrophic event as well. And it may induce, because of if you need to give sedation or other medications, it might induce some respiratory insufficiency as well. So it's not without having its risks. So as a general diagnostic test, you probably won't see it, but in some settings, particularly if they're in a patient you're thinking about thrombectomy, they may end up going for one. CTPA has pretty much supplanted angiography, and it has for some time now, 20 years or so. It's got a 92% sensitivity, 95% specificity when it's compared to angiography or to a high-prob or a normal VQ scan. So in that sense, it's a great study. It's specific. It's readily available. It's rapid. It has potential to diagnose other disease processes, so even if you exclude an embolic event, you may still be able to gain some information that's useful and that might explain the patient's symptoms. And the technology is always getting better, so the amount of radiation they're exposed to is getting less. The speed with which it's done is getting faster. The detail, the resolution is always getting better as well. The disadvantages, it still requires some reader expertise, and I suspect everybody or most people in here, if you've seen enough of these patients, have probably already had the experience where one person reads it, or you get an initial read and then you get your formal read later, and it's not quite the same as the initial read. And there are other things that can impact the quality of that read, and we'll talk about that in a minute. But not every study is a great study. I mean, we sort of take it for granted, but there can be a lot of technical limitations in some of the studies. They're not always perfect. And the less good that study is, the more chance there is for reader variability or interpretation. The other thing we run into is that it requires contrast. So many of our patients have renal insufficiency, and you have to make the decision, is it worth giving the contrast for? Can I get an alternative way to make this diagnosis? So, and then in patients that have contrast allergy, it can present a challenge too, because it may not be a modality that's immediately available. In the PIOPED study, diagnostic accuracy varied among institutions. So the sensitivity actually varied from 50 to 98%. So some places seem, at least at that time, seem to do it well, and others not as well. Specificity was generally good across the board. And then the likelihood that a patient that has a PE with a negative CTPA, again, is going to depend on your pretest probability. So if you have a low or intermediate suspicion and you get a negative CTPA, it's pretty good at excluding a pulmonary embolus. On the other hand, if your clinical suspicion is really high, a negative CTPA doesn't completely exclude that possibility. So you just need to keep that in mind. CT angiography, however, if you do miss one, if it is negative and you don't treat it, is it really significant? And that may be, that is debatable. This is a prospective study of 1,000 patients. If they had a negative CT, a negative lower extremity Doppler, and a low to intermediate clinical probability, then less than 2% of those patients ultimately developed a PE, even if it were missed. So it may not mean anything if you miss that. And actually, if you look at the current guidelines, if you have a subsegmental PE, okay, in a patient who otherwise has really no other risk factors, and your suspicion for progression or recurrence is going to be low, you may not even need to treat that patient. Okay? So 5% incidence of PE if they have a negative CT and a high clinical probability. So there's always it's still low, but there's always the possibility that one could still be there. But in general, if you get a negative CTPA, you're probably, even with the high clinical probability, you still may be safe in terms of doing it. And you can follow up with other studies, so you can do a serial ultrasound exams over the next couple of weeks, or you can repeat some other imaging study and pair it with another modality. So for the most part, anticoagulation can be safely withheld in moderate to low clinical probability with a negative CT and a low extremity ultrasounds. In the ICU, though, again, it's not always a perfect test. Looking at 100 patients undergoing CTA and venography, 25% were non-diagnostic. That's fairly high. That's 1 in 4. usually due to motion artifact, poor contrast opacification, or hardware artifacts. So there's a line, a wire, pacemaker, something shadowing from that just interferes with the imaging. Again, when it's a good quality exam, readers, different readers, the correlation between them tends to be pretty good. When it's low quality exams, though, they're much more variable in their reads, and can be. In terms of the I had trained and where I did my residency and fellowship, never saw a normal scan. It was always low prob. But if it's really called normal, then whether your likelihood is high, uncertain, or low, it pretty much, it effectively rules out a pulmonary embolism. If it's a high prob scan, then you're much more, and you have a high clinical suspicion, then it rules it in. You can make the diagnosis. And the same thing for an intermediate. If it's unlikely, it may be lower, but it still does it fairly well. The problem is when you get in, if you have a low prob or an intermediate, indeterminate intermediate probability in terms of your read and your clinical suspicion. So even a low prob scan in a patient with low probability, with your pretest probability being low, is at some risk for still having a PE that's not detected by this, but might be detected by another means. And as your suspicion goes up, then it moves up, but it's still an imperfect test. So the problem that we have with the VQ scan is when you get in between. You don't see that many normal scans. You do see them, but you don't see as many in the population that we're studying. And you don't see that many high prob scans, okay, where they actually call it high prob. What you get in between are a lot of intermediate and low prob scans. So you often have to do something else to make the diagnosis. Now, what you do, whether that be ultrasound exam, the echo exam in terms of maybe putting it together if CTPA, but most you may still need a CTPA if it's available to get. So high prob scans only identify about 50% of patients with PE overall. So even if they have a PE, there's only about a 50% chance they're going to have a high prob scan. Most are going to have an indeterminate or a low prob scan, or as many. An abnormal scans, though, if you look at all the groups together, low prob, intermediate, and high probability scans detect about 98%. So they're sensitive. It's just not very specific. And about 60% of scans are going to be indeterminate. So the majority of the scans that you're going to see are going to fall in that group. And of them, about a third will have angiographically proven PEs. A normal scan rules it out. We've already talked about that. But a low prob test still has about a 15 to 25% chance of having a PE. So again, what you do with it is going to be determined by what your pretest probability is. However, if they had a low prob scan, their risk of dying wasn't that great. And if you have a low prob scan with a normal D-dimer, then you may not need to do any additional workup or treat the patient. If you get in the intermediate, it's just going to depend on what your results of your other workup are and what your pretest probability is. Lower extremity Dopplers by ultrasound. If you make the diagnosis, you're going to treat the same as you treat a PE, a DVT. They're going to be treated the same. They're going to get anticoagulation. It's non-invasive. It's easy to perform. Now it's basically you can do it at the point of care at the bedside. It is insensitive for diagnosing a PE because only about a third of patients with a PE you can confirm a DVT on. So most patients that are diagnosed with PE don't necessarily have DVT at the time of their when they present. Serial exams are good in terms of following patients because if it's serial exams are negative, you can feel more comfortable about perhaps withholding treatment. And it may be helpful when you get non-diagnostic VQ scans or positive D-dimers. Echo, like many of the other ones we talked about, it's insufficient for the, it has insufficient sensitivity to make the diagnosis of the PE because only about 30 to 40% of the patients with PE have abnormalities that's suggestive of PE. But it can be, and it's probably one of the primary tests that you're going to do to risk stratify patients and to gain prognostic information because the presence of RV dysfunction and dilatation is going to be associated with greater risk of adverse outcomes. The things that you would look for, direct visualization of the thrombus occurs rarely, but it may be possible and may occur. RV dilatation, RV hypokinesis with sparing of the apex, McConnell's sign, interventricular flattening, paradoxical septal motion, tricuspid regurg, loss of inspiratory collapse, the IDC, evidence of pulmonary hypertension, and if you see it, a patent foraminal valley, and that's important because not so much from in playing a role in the pathophysiology or the pathogenesis of the PE, but because if you do detect it, it's an important predictor of adverse outcomes in patients that do have PE. At least in this study, the death rate amongst patients with a PFO was 33% as opposed to 14% in those without a PFO. There's a much higher incidence of ischemic stroke and peripheral arterial embolism, so paradoxical emboli. And the overall risk of a complicated course was about 5 times greater in these patients. So if you happen to see it or pick it up on the exam, then it may affect the way that you treat it in terms of maybe how early you would let that patient go or how you want to manage their anticoagulation. MR angiography, I've never seen this. I don't actually know if we even, do you know if we do it here? I don't even know if it's available. But it has been a modality that's been studied. It has potential to avoid exposure to iodinated contrast material. So in that sense, you might go, oh, I can use it in a patient with renal insufficiency or acute renal injury, but that advantage is offset by because of the contrast material, nephrogenic systemic fibrosis. So you substitute one problem for another in a renal failure patient. It's limited by respiratory cardiac motion. They need to do a longer breath hold. And it's certainly in a critically ill patient, it requires a longer stay out of the ICU environment, and that can be critical and limiting for some patients. Technical inadequacy is about the same as it is for CAT scans, or at least for ICU. This was everyone, though. These were patients who weren't necessarily critically ill, but 25% technically are inadequate. Sensitivity was fairly 78%, but specificity was pretty good and technically adequate scans. And the addition of venography improves the results, but then you get a greater number of inadequate studies. And generally, I don't think there are that many centers that actually perform it, but if you happen to end up at one that does, then it may be something that can be considered. So in terms of the challenges presented to us in our patient population, VQ is often limited by other coexisting lung disease, so there's a problem there sometimes. Peripheral edema may interfere with the ultrasound exam. There's a higher prevalence of renal failure that may affect your ability to give contrast. They're often short of breath, so they can't do an adequate breath hold. There may be poor contrast or dye enhancement. You get these artifacts. And again, they have to leave the ICU, which may be problematic in some patients. So a few words about treatment. Briefly, anticoagulation. We'll talk about thrombolytics, embolectomy, and IVC filters. Actually, I don't know that I have a section on IVC filters here. The drugs that are available for the initial treatment are unfractionated heparin, low molecular weight heparin, fondaparinux, or some of the options as far as initial treatment goes. Classic, but we also have the newer anticoagulation agents. Rivaroxaban and apixaban are both approved for primary as initial treatment and only treatment, and those that are symptomatic but hemodynamically stable. Okay, it's not the agent of choice for the patient that's hemodynamically unstable. The Einstein PE was the study looking at I think that put enoxaparin, but I think that was supposed to be rivaroxaban. Oh, enoxaparin for the control arm, sorry. And presenting, and there was less bleeding and no difference in mortality. I believe it was the Amplify study for apixaban, but both of those show that either agents can be used as primary treatment. And they have a lower bleeding rate. It may be relevant to the older patient and those with some renal impairment. Thrombolytics is probably, I think, where the largest question in terms of what we do. Should we or shouldn't we? It does accelerate the lysis of emboli. If you look at some of the hemodynamic parameters, you get improvement. You get a quicker improvement in RV function and lowering of PA pressures. It comes at the risk of increased hemorrhage. So the cumulative rate of major bleeding, at least in some studies, has been 13%, upwards of 36% in some registries and cohorts. And the risk of intrafatal or intracranial or fatal hemorrhage is around 2%. So it's not insignificant. And it has been as high as 4% in some registries. It's not the same as giving, the cardiologists use thrombolytics all the time, but this is a little bit different disease, because if you look at the overall mortality rate for thrombolytics in MIs, for example, it's around 0.2%. And so here it's 10%. So something's different at baseline. So just because you can do it, give it with impunity, I guess, in some settings. For cardiac disease, it's a little bit different disease. It's indicated for massive PE, so whenever there's hypotension or shock present, it's really the only thing that you have that's going to make a difference in survival for the most part. So that patient with massive PE is pretty straightforward. You're going to probably give a lytic unless you absolutely can't, and then in that setting they may have to go directly to thrombectomy if you have that available as an option. And then there are other relative contraindications or indications. If they have RV dysfunction, RV clot, they have refractory hypoxemia, maybe they have a substantial diffusion defect, so there you're basing it on the distribution clot rather than the physiology of it, or if they have extensive DVT, so you're worried that, okay, this patient's marginal, it's got an extensive clot burden, and I'm afraid if they have another one, they won't be able to tolerate it, that kind of thing. And that's going to be judgment, because you aren't going to find a lot of guidelines there, so it's going to be based on you and or your attending's judgment in terms of what you do in that setting. There are some absolute contraindications: hemorrhagic stroke, active intracranial neoplasm, recent CNS surgery or trauma, active or recent internal bleeding. Most everything else is going to be a relative contraindication. If there's a bleeding diathesis, uncontrolled severe hypertension, CPR, I don't. There's some settings, certainly in a code, where you have a really high suspicion of a PE as being a cause of it. Thrombolytics may be your only salvage and life-saving therapy in that particular patient. So, but it's listed non-hemorrhagic stroke within 2 months, surgery within the preceding 10 days, and thrombocytopenia. Generally, streptokinase, urokinase, TPA are going to be your options. TPAs are preferred due to shorter infusion duration, and I think most guidelines suggest using the short duration infusion over the longer duration infusion. Although when it's paired with catheter-directed stuff, they sometimes will do the longer infusion. Generally, you want to give it peripherally. That's based on prior work, but again, those which we have the ECOS available to us, and it may be, so we're seeing patients that are getting catheter-directed therapy, and try to talk about that here in a second. And usually during the infusion, you may stop the heparin, but you begin it afterwards. So some of the data supporting thrombolytic therapy, I just picked one that the MAPIT-3 study. There's MAPIT studies, there's MOPPET studies. I don't think there's a MOPPET study yet, but there are a host of studies and variants of studies looking at different combinations of things. This study looked at heparin TPA versus heparin placebo for QPE. They had pulmonary hypertension and RV dysfunction, but without shock, so what we would call a submassive PE. And the primary endpoint was in-hospital death or clinical deterioration. And that was defined by whether they needed pressors, whether they had to get salvage thrombolysis, whether they had to be intubated, had to be coded, or had to go for emergency intervention. And what the study shows that there were more cases of clinical deterioration in the heparin alone group than there was in the group that got heparin plus TPA. Yet there was no difference in hospital mortality, but there was no difference in major bleeding between the two groups, suggesting that you might be able to give these agents with perhaps not the risk that we thought. So the study, I think, that drives what most of us think about, or it drives current thinking about thrombolytics, is the PETHO study, which is a multi-center, double-blind, randomized controlled trial with 1,000 patients, so a reasonably sized study, especially as far as PE studies go, looking at heparin placebo versus heparin TPA in normotensive patients with intermediate risk. So these are submassive PEs. They had to have an abnormal RV on echo or CT, so it had to be dilated or dysfunctional, and they had to have a positive troponin. So they had to have both of those to be included. The endpoint was a composite. The primary endpoint was a composite endpoint, so it was death or hemodynamic collapse. So they had to have some hemodynamic decompensation. And then the safety outcomes were major extracranial bleeding and or ischemic or hemorrhagic stroke within 7 days after randomization. And what the study showed was that there was a significant reduction in the composite endpoint in the patients that got heparin plus TPA. So they had, in that composite endpoint, there was improvement, 2.6 versus 5.6, so 50% change. There was no difference in mortality at day 7. So most of the difference is driven by the hemodynamic, the lack of hemodynamic decompensation. So that was for the composite in the composite endpoint. Mortality didn't look that different at the 7-day. But the reason the patients died were different between the two groups. Because the group that got TPA died more from hemorrhagic complications, whereas the other group died more from hemodynamic decompensation, right, related to the PE itself. There was a significant increase in major hemorrhage, so extracranial bleeding occurred in 6.3 patients in the TPA group versus 6. So basically, the benefit in survival is offset by a similar increase in major hemorrhage. So what are the caveats about the studies? The patients didn't have to, it wasn't at point of care diagnosis. They can be enrolled in the study up to 2 weeks after the initial diagnosis. So they could have been in the hospital already, had been there for a week, and go, hey, our guy's got a PE, you want to put him in the study, and they could be enrolled in the study. So they didn't all get thrombolytics at the very beginning. So you could say, well, perhaps that some of these patients were going to do well anyway, and that's why the TPA arm looks better. On the other hand, about 23 or 5% in the placebo group received rescue thrombolysis. And you could say, well, maybe that rescue thrombolysis was beneficial and it helped that group look better, even though they're in the non-thrombolytic group, the placebo group. So you could look at it, they may be offsetting either way. The composite endpoint, rather than just mortality, may be an issue. They didn't assess morbidity for chronic pulmonary hypertension. There have been other studies that suggest that lytics were beneficial in reducing the incidence of chronic thromboembolic pulmonary hypertension after having PEs. They didn't assess that. They didn't look at the lower dose. They used what we would call a standard dose. They didn't use a half dose or a lower dose to offset the potential risk of hemorrhage or to see if it would. So industry funding, many of these studies, if it's a well-designed study, these studies don't get done without some industry funding. So you just have to take into account and just look at the study. So the Moffitt study is a single center, smaller study, 121, looking at safe dose, so a lower dose of TPA and heparin versus heparin alone. And then they looked also at the occurrence of pulmonary hypertension and recurrent PE afterwards, so up to 28 months. They had to have a symptomatic PE. They had to have radiographic evidence of thrombotic inclusion of 70% of a lobar or pulmonary left or right pulmonary arteries, or if they had a high prop scan, they had a mismatch in two lobes. So they looked at clot burden rather than sort of the physiologic way. That was their definition of being enrolled as a sort of submassive or a major pulmonary embolus. It wasn't based on physiologic criteria, but instead on the clot burden. RV enlargement dysfunction and biomarker elevation was measured, but it wasn't a requirement to be in the study. So what they found was that half-dose TPA associated with a long-term reduction in the incidence of pulmonary hypertension. There was no difference in mortality, and there wasn't any significant bleeding in either group. So what some of the people have taken, what some have taken from the study is that if you give a lower dose, you may be able to get the benefits without taking on the risk of bleeding or as much risk in bleeding. The caveats here that moderate PE was defined by anatomic rather than a standard definition that we use clinically to call it submassive. And the way they measured the PA pressure, their pressures were about roughly 10 millimeters of mercury higher than the way most people would do it. And they also had a higher incidence of pulmonary hypertension afterwards than what most previous studies have shown. So those are the caveats, but nonetheless. This was looking at another study looking at a slightly different approach, but what was called a drip drug and discharge approach of using one of the newer agents. So here they did safe dose thrombolysis in addition to rivaroxaban for moderate PE. And the endpoints were bleeding, recurrent clot, death, and PA pressure. They had to have a symptomatic PE. They had to have radiographic confirmation. Again, use clot burden as part of the study, but they also had to have, for moderate, but they also, for to be classified as severe, they had to have physiologic features or alterations. And then what they did was they gave the safe dose, and then they gave rivaroxaban. There was no bleeding in the hospital. Recurrent rate there was not significantly different. Mortality, no in-hospital mortality. PA pressure, though, was dropped in the treatment group, and the duration of hospitalization was significantly less when they did that. So another possibility or a way to treat even in those with more severe or physiologically altering PE. So I think if you look at the data as a composite, what you can say is that thrombolytics most likely improve mortality. So you get a survival benefit if you give thrombolytics. May not be huge, but the composite is that of these studies is that you get a survival benefit. On the other hand, it's offset by the increased risk of hemorrhage, so that you get an increased risk of major bleeding. So here's the, looking at this, the number needed to treat to affect a change in mortality is 59. The number needed to harm for major bleeding is 18 and 78. On the other hand, if you look at it, and it's done as a subgroup analysis, but most of the risk may be borne by older patients. So the older you are, you may be more likely to have developed hemorrhage. So it was much less common in patients less than 65 than those over 65. Here the number needed, if you just look at those at less than 65, the number needed to harm is 176. So the risk-benefit ratio may be a little bit different in younger patients than it is in older patients. And that may factor into your decision-making in terms of who you decide you will or won't treat with thrombolytics. In terms of catheter-directed thrombolysis, most of the studies are small. A good number of them show the improvement in hemodynamic parameters. So if you look at pulmonary artery pressure, you see improvement in pulmonary artery pressure. You might see improvement in other indices of right ventricular function. And most of them don't show significant risk of bleeding, okay, because they're using maybe using a lower dose of it. So in that older patient, maybe this is what you want to think about doing because of that. Although again, larger studies, it really hasn't been compared. There aren't a lot of large studies, or any large studies I'm aware of right now, that compare this to standard systemic therapy. The other question is whether the ultrasound, the catheter part, is the ultrasound catheter part is actually doing anything or not. If you look at in the groups that get ultrasound versus standard catheter delivery, there really was no difference in the PA pressure or the change after the procedure in this study. And this catheter, this is an older study, but the catheter delivery is not a new concept. It was thought about a long time ago, and that's actually what this paper in '88 investigated. And what it didn't really show to have any benefit. So basically, if you were going to give it, and certainly if you have to give it in a crisis situation, you don't usually wait. If there's no contraindication, you go ahead and give it systemically because you're going to get the benefits without much difference in risk in terms of doing that in that particular patient. So the newer we'll see as more studies come out. I know it's offered. I know we've had patients at the VA that have been sent up to specifically get the catheter. I don't know. Are you a believer?
Yeah.
Because?
Well, I mean, the preclinical stroke data looking at catheter-directed thrombolysis with the addition of ultrasound showed much better pictures of the clots and activity of the actual. But that led to the design of the ellipsosome that covers PA molecules, which we're still trying to do. That being said, even without getting into that, under electron microscopy, the clots break up better under ultrasound. Even if we're just seeing edge of clot, you can start opening it up so you can find it.
So there's animal data that certainly goes with it, supported by animal data. There actually have been some studies though where they did serial studies afterwards. So if you have a focal clot and a focal clot that's sort of proximal that the catheter can get to, I guess it makes some sense to me. As the clot's further out, or if you have bilateral clot, it's kind of hard for me to envision how it works. And there've actually been that study where you give it and the clot on the other side, even though you don't do the catheter, the ultrasound part on both sides, the clot on the opposite side still got better. So I don't know if it's just that we haven't found the bottom of what we need to work in terms of the dosing and everything, because it tends to be a smaller dose. But they deliver it differently too, right? They deliver it over a longer period of time. The idea that it circulates and continually, that it won't be used up through a first pass effect type thing, and it will be there. So, I mean, I don't know where I stand on it. I think probably for a patient that's at I perceive to be at a high risk of bleeding, I think that I see that as a potentially advantageous modality for somebody that is not really, that has that risk. I'm not sure that I would pick that over systemic therapy if I had to give it.
I think we're really trying to figure out what to do with the patient who's actually an extremis. We want to get the catheter and see if we can put it actively down in front of us, hence the activation. I mean, if you go to MI on there, the PERT team has a column.
Yeah.
The pulmonary embolism response. Guys, you mad at me now because we'll be more this call, but I mean, the idea being that can activate those make inflammations on ECMO circuitry during procedure. So by the time
So this is just the guidelines as they stand now, the ACCP guidelines. Most patients with acute PE not associated with hypotension. They recommend against systemically administered thrombolytics. However, in selected patients that deteriorate and that after starting anticoagulation but haven't yet developed hypotension, but they're at low bleeding risk, then you might consider it as salvage therapy. The British thoracic guidelines are the same. The American Cardiology are pretty similar with that. I couldn't find updated. The guidelines from the ACEP were from 2011, and those guidelines that was before PITHO and these other studies just said there wasn't enough data to make that. So, the medical society guidelines are generally saying basically save it for salvage therapy or particularly unique situations in terms of that. But I think you will have to use some clinical judgment. So, for example, the patient that they're in that intermediate group, but some people just have a worse looking RV than others, at least by echo, and that may be, if I asked 10 people in the room to say, does this one look really bad, or is this just moderately bad, or whatever, I don't know. But I think if your perception is maybe it looks bad and maybe there's more gas exchange than abnormalities than what it might drive you more towards treating that patient. So I tend to say that as more of a salvage therapy. I tend to withhold it and see. It's hard while it's not the standard definition, on the other hand, if a patient's got a ton of clot burden and you're thinking, well, can they really tolerate anything else, then I think that's a little bit different. And how you synthesize it, I guess everybody right now is just until there's somebody comes up with a better protocol or better do it, there is going to be a little bit of art here in terms of what you decide to do. In terms of embolectomy, you have the option of catheter embolectomy or surgical embolectomy. I won't go through it in time. Surgery can be performed at select institutions if they have expertise. High mortality rate if in septicemia, it does have a high mortality rate, but in centers that have expertise, it's down around 10%. And it seems like it ought to be a lot higher to me than that, so that's probably pretty good. If you've got a 90% survival in that setting that you need emergency thrombectomy. Generally, it's going to be in those that are hypotensive and thrombolysis is contraindicated or ineffective, or if they have clot, extensive clot, maybe in the RA and the RV. So you should do a TE beforehand. Mortality rate is higher in those that have had cardiac arrest already. So in terms of the algorithms, you perform your initial assessment to stratify risk, and then you're going to do your diagnostic assessment based on that risk and institute therapy accordingly. Your strategy is generally going to depend on your initial clinical assessment. That's where it's going to start. Is a patient at high risk, intermediate risk, low risk? And then you should pick your test accordingly from that. If it's suspected high risk or massive, you pretty much have a simpler path. You get your study and you treat. If you have no other option but to assume it's high risk and not something else, you might even have to consider empirical treatment occasionally. That may arise. But in general, you want your clinical pretest probability to drive the management. In most settings, use of a validated diagnostic strategy is better than just having each person do what they think on their own. So a strategy might look something like this. You do your clinical assessment, and based on how you classify them, you're going to work on your diagnosis and your stratification, and then determine your treatment based on that, and then determine or think about the long-term complications that may or may not occur. In terms of resuscitation, reversing the cause is the primary goal. So thrombolysis is the only evidence-based intervention to improve mortality. So they're either going to get thrombolysis or thrombectomy generally. You need to quickly identify whether there are any contraindications to thrombolysis, and you need to arrange an alternative if there are. With regards to fluids, be careful. Some CVP elevation is necessary and may be helpful in improving RV filling and cardiac output, but in patients that already have a severely dilated RV, giving more volume and expanding that RV further, there may not be any room left on their Starling curve to affect any improvement, and then you may just act by dilating it further, increase wall stress, cause more ischemia, and worsen their cardiac output. So you need to avoid over-distension. So if you give fluids, give enough, but not more. Vasopressors and inotropes, consider them early. There's not a lot of data to say that norepinephrine, whichever one you use, one's more effective than the other in terms of randomized trials. There's not going to be any data. In animal data, Levophed may be better, and it may cause some venoconstriction, peripheral venoconstriction to support preload. Epinephrine may be a stronger inotrope than a pulmonary vasodilator. Dobutamine may increase contractility some, and it may cause some mild pulmonary vasodilation, but you may get systemic vasodilation as well that you don't want. This is a setting where I think you can consider pulmonary vasodilator therapy. So inhale, because it may the vasoconstriction, diffuse vasoconstriction is probably mediated, so release of humoral mediators. So nitric oxide may be something to consider in this particular setting. If you have to intubate the patient, be cautious. Patients with massive PE usually die from hemodynamic collapse rather than their respiratory failure. So it's usually that, and patients that when the RV is under duress, it doesn't tolerate positive pressure very well, positive pressure ventilation. So you need to be really careful. Probably should have pressors ready to go or already if you have to intubate the patient. And then salvage thrombolysis. So if you look at patients that receive thrombolysis during CPR, 35 to 38% might actually survive if PE is what caused their code. So across the board, just giving everybody that has a cardiac arrest thrombolytics does nothing, doesn't change overall survival for that group. But if you really think, if you have a strong reason to think that this patient is dying of a PE or coded because of a PE, you can give thrombolytics in that setting, and it may salvage, it may allow you to rescue the patient. Just remember, you need to do your code long enough to give it a chance to work. So it's not something that you should give and then 3 minutes later go, well, it didn't work, we'll call them this kind of thing. So if you're going to do it, and try to do it as early as you can. And then talk about ECMO. ECMO may be quite beneficial in getting these patients to something more definitive in terms of getting them through. So looking at different options, ECMO versus third embolectomy. This is a group, 13 patients, 9 of them survived. So 69% survival when it was paired up to with other therapies and everything. So ECMO can be life-saving, and we have the potential to do it here in that setting. So just keep that in mind as a bridge to more definitive therapy. So as usual, I left no time for questions, which is perfect, so I don't have to deal with any on this topic, but I'll try to answer if anybody has one. Great. Guys, have a great day.